The majority of patients nowadays who receive upfront therapy with combination chemotherapy plus a targeted drug do have either response or stable disease. Very, very few patients have primary refractory disease and progression on frontline therapy. This is very good news for our patients that they can expect a good outcome of frontline therapy. Unfortunately, as we keep patients on combination chemotherapy for a prolonged period of time, side effects become more prevalent. And therefore, at around 4 to 6 months into treatment, as the side effects become more prevalent and the disease control becomes less of an issue, it is a accepted strategy to try and decrease the chemotherapy to enhance the balance between benefit and toxicity. Usually the drug that you would remove at that point in the program would be oxaliplatin or irinotecan, especially with oxaliplatin because of the cumulative neuropathy. It is advisable not to continue the oxaliplatin until progression and rather to stop after 4 to 6 months and then start maintenance. Maintenance regimens could include capecitabine alone or capecitabine plus bevacizumab or a 5-FU regimen plus bevacizumab. Any of those options would be reasonable. In my practice, I tend to use capecitabine plus bevacizumab because I feel the data that supports prolonged disease control with that regimen is slightly better. In addition, I feel the capecitabine offers patients an oral option, which also has an impact on their quality of life. As we see in this patient, many patients unfortunately do progress while on frontline therapy. On the average, the time for progression is around 9 to 11 months. And at the time of progression, there are several options that could be entertained. Those options would depend on the sidedness of the tumor and the mutational panel. In our specific patient, given the patient has disease in the ascending colon, I would prefer continuing with the bevacizumab into the second-line setting, continuing the 5-FU into the second-line setting, and then exchanging the oxaliplatin to irinotecan, so the patient would be on FOLFIRI bevacizumab second-line setting, and reserving the EGFR inhibitor for later lines of therapy. In my practice, I reserve EGFR inhibitors for later lines of therapy, like third line and beyond, in patients who have RAS wild type and tumors in the right side of the colon. I usually would prefer using bevacizumab in the first and second line and keep maintaining the EGFR option for later on. The future for colorectal cancer is going to be us looking at a more personalized approach for patients. Personalizing the approach will depend on molecular profiling as well as better imaging and better staging. With better imaging and better staging, we will be able to select the patients who benefit from metastatectomy. With molecular profiling, we will be able to select subgroups of patients that benefit from specific therapies. We are already entering this age because now we select EGFR inhibitor based on RAS mutation and sidedness. We have specific therapy for BRAF mutated colon cancer that is evolving. And we have specific therapy for patients who have MSI high tumors and specific therapy for patients who have NTRK mutations. And this list is going to expand and grow. I think next will be specific therapy for patients who have overexpression of HER2/neu. And as this list expands and grows, we're going to be able to tailor therapy more to the patient's needs and select therapy that has bigger impact, although it's applicable for smaller subgroups of patients, but has bigger impact in those small subgroups.